Well, good morning. It is 9:30. We will kick off our workshop called When Prevention Fails. It is my pleasure to introduce you to our two presenters. Dr. Stephen Messner, he's child abuse pediatrician at Children's Healthcare of Atlanta. Dr. Messner joined the child protection team at Children's Healthcare of Atlanta in the summer of 2007. He was appointed medical director in January 2016. Dr. Messner is also a fellow of the American Academy of Pediatrics and a member of the Georgia AAP section on child abuse. We would also like to welcome Dr. Angie Boy, Program Manager, Prevention and Training with Stephanie V. Blank Center for Safe and Healthy Children at Children's Healthcare of Atlanta. In Dr. Boy's role, she is responsible for overseeing the implementation of multiple projects related to child abuse and neglect, including child sex trafficking, prevention of child sexual abuse, and mandated reporting of child abuse and neglect. Dr. Boy also sits on several state-level work groups, including the statewide Human Trafficking Task Force, the Child Fatality Review Project, and the Child Protective Services Advisory Committee with CAPTA. Welcome and thank you so much to the both of you.
Thanks, Jennifer. All right, let me. Right, our system's just being a little slow presenting it. Hopefully you guys can see. Jennifer, can you let me know what you see on your screen? All right, well.
We're in good shape. We are seeing your slideshow.
Okay, good.
Because we weren't.
We were not. So. At the bottom, that's right. Sorry, we're technical difficulties this morning. Okay, there we go. So we're going to be talking about when prevention fails. So this is looking at when we really are needing to get into the more tertiary prevention, and we're looking at, and we'll sort of give an intro into some of the other topics that'll be talked about through the next couple of days. We're going to talk about the importance of prevention and look at what the current prevention landscape is. Then Dr. Messner will talk about sort of the three big areas within the child abuse field where you really see the impact of failed prevention efforts. So we're going to look at physical abuse, abusive head trauma, and then child sexual abuse. And we're going to talk about what changes are needed, what should we be doing in our communities to actively prevent child abuse and hopefully lessen the cases of children being abused in their families. So as I mentioned in the opening plenary, adverse childhood experiences are 10 initial things that children experience within their childhood. The initial study was done in 1995 and 1997 in the San Diego area by Kaiser Permanente. And what the two primary physicians who were looking at this found was that people who had one of these 10 identified ACEs were significantly more likely to suffer from chronic conditions. So things like heart disease, cancer, high blood pressure, all of the chronic conditions that we really work in public health towards eliminating were significantly impacted by things children experience or things adults had experienced in their childhood. So bringing the tree back up that we looked at earlier, we see the 10 ACEs at the top. So experiencing mental illness in a caregiver, parental separation or divorce, physical, sexual, and emotional abuse fall into sort of three separate. That's how you get to the 10. Then neglect, presence of substance use by a parent, and then parental incarceration. As things have expanded past the initial study, we really have expanded some of the experiences to look at caregivers, not just parents. So recognizing that kids sometimes live in multi-generational households or children are being raised by grandparents, they really have gotten away from using just the term parent and really talk more about caregivers. But we also know that there are adverse community environments that play a significant role in raising the risk factor for adverse childhood experiences. So things like unaffordable housing, racism, high rates of joblessness in a community, presence of community violence, the presence of poverty in a community really play a role in what supports parents have and resources that parents are able to access. What we also see in a lot of these adverse community environments, you have the presence of a lot of these issues, but there's also a dearth of community resources. So you may have high rates of joblessness, but there are no job training programs, or the nearest job training program is a significant distance from where people are living, and transportation is an issue. There is unaffordable and unsafe housing in communities. There's no good access to childcare, or childcare is cost prohibitive. So a lot of these all play together to raise the risk factors for some of the adverse childhood experiences. But then there are also adverse collective historical events that play a role in the adverse community environments and then in ACEs. So things like the historical impacts of slavery and genocide, mass incarceration, forced displacement through war, natural disaster, things of that nature. Then we're also seeing in the last 18 months the adverse collective impact of a pandemic. And so that is playing a role in a wide variety of different issues. And I think we will begin to see, as the research plays out, the significant impact that the pandemic is playing on a lot of the adverse community environments that then play a role in adverse childhood experiences. So we know that ACEs are common. Around 60% of adults surveyed across 25 states reported they experienced at least one type of ACE. Nearly 1 in 6 reported they had experienced 4 or more. And there's a dose-response relationship with ACEs. So the more ACEs you experience, the more impact you will see in chronic conditions. So there's a good bit of research that plays that out. We know that preventing ACEs can reduce a wide variety of health conditions. So how many cases could we prevent of heart disease, depression, cancer, if we work to prevent adverse childhood experiences? We also know that risks are not the same across the spectrum. Females and several racial and ethnic minority groups show a greater risk for having experienced 4 or more types of ACEs, which, if you then think about the adverse community events and the collective historical events, you can see where there is a logical progression that the risk would be increased because you've also experienced these adverse community and collective historical events. We also know that ACEs are incredibly costly. The total costs are in the billions, hundreds of billions of dollars each year. So how much money could we save our health system and save our communities if we put more money toward primary prevention? So the problem we run into is that how we spend our money in prevention is backwards from what it should be. So this gives you an idea of what it looks like right now. We spend the vast majority of our dollars working on tertiary prevention. So this is focusing on families who already have experienced maltreatment. So this is medical care, court costs, foster care, all of that money that has to be spent after abuse has already occurred. It's largely reactive. So we see a problem, we react to it. We put the child in foster care. We maybe arrest the parents or put the parents into some form of parent support, family preservation. But that's where the bulk of our money is going. We do put some money towards secondary prevention. So we focus on our communities that we know are at higher risk. But again, we're still having to pick and choose which families we can support because we don't have the adequate funding. And then our primary prevention gets the smallest amount of money. So these universal maltreatment prevention efforts that go to everybody, So what could that look like in our communities if we had more money? And a lot of that is where we run into issues is we would like to do these programs, but there's no funding support for it. Or we have funding to get it off the ground, but it's not sustainable long term. So how do we reframe our prevention efforts? And so what we want to do is make sure we've got that support ahead of time. So we flip the triangle, and we'll talk about how we flip it after we look at some of the areas where prevention has failed and we end up with a child having been abused. So I'm going to turn it over to Dr. Messner. Do you want to make one quick warning? There are some slides on here showing injuries. They are not graphic by nature. They are just a little more shocking than some of what we present. So we just wanted to give you that warning ahead of time.
Yeah, so feel free to avert your eyes if you don't want to look at those slides. But I think it's important for all of us to, get a clear picture of what physical abuse injuries look like. I'm going to talk about, physical abuse first. And just like other types of abuse, no socioeconomic group is immune. And we know that this occurs in all age ranges. The AAP tried to give some guidelines to providers to help distinguish between corporal punishment and abuse. And so they recommend if an injury lasts greater than 24 hours, that kind of crosses over that threshold. We know that you can definitely have physical abuse injuries that do not leave any kind of cutaneous findings, so not seeing anything. So the lack of seeing anything on the surface of the body does not mean that a child has not been physically abused. But this was put in place just to help providers and other professionals with that distinguishing between abuse and punishment, because we know in 19 states that they do allow corporal punishment, including here in Georgia. A little bit about the age of victims. This is some older data from NCANS, which is data that's collected from all across the U.S., Puerto Rico, and D.C. And just want to point out that where we see the highest rates of victimization is in this less than 1 year of age group. And you see that it kind of trails off after that. You have this big spike in that first year of life. And when we look at fatalities, we see the same thing. So in the most severe form of child abuse, the fatalities, the largest percentage of folks who are being victimized are these very young children, so less than 1 year of age. And they are the most vulnerable. And so when you think about the most vulnerable populations, it's going to be you're very young, you're very old, and you're disabled because they're reliant on other folks for their care, as well as an inability to accurately communicate. So that's why it's really crucial when we look at this data and we see that this less than 1 year of age range, that if we see any injuries in these children from a physical abuse standpoint, that we take it seriously because we know that they're at very high risk for being more severely injured or potentially becoming a fatality. Some of the outward signs that we see of physical abuse are patterned injuries, injuries that are not over bony prominences. And I'm going to give you guys a nice mnemonic that's been developed to kind of help identify the areas of the body that are unusual to be injured during normal play or from accidents. If the injuries if they're not consistent with the developmental stage of that child, so you have to really look at whether that child is developing normally or is delayed. If there's adult-sized bite marks, we'll talk about the issues with making that determination sometimes, handprints, and then patterned burns. So this is that clinical decision rule that I was referring to. It's called 10-4 faces P. Some of you may have heard this. It started off initially as 10-4, meaning the T, meaning torso, E for ears, N for neck, and 4 meaning that this was validated in children up to 4 years of age. And also that 4 reflects that in a child less than 4 months of age or so, when they're not mobile, that they shouldn't have any injuries on them. And they did a subsequent study that just got published in April of this year, where they validated this clinical decision rule, and they determined that there are other areas of the body that were statistically significant for teasing out whether this was an abusive injury, more likely an abusive injury than an accidental injury, and that's the faces P. So if it's injury to the frenulum, at the angle of the mandible, on the cheek, the eyelid, and subconjunctival hemorrhages. And then the P is that pattern bruising. I'll go over some examples of this now. So these are the photos that we were talking about. So this is the T, so torso, and torso meaning anywhere from the shoulders down through the hips, including the genitals. So if we see injuries on there in a child less than 4 years of age, we should be thinking, how did this child sustain this injury, and really getting a good history. If there's no history or it seems improbable, then we need to consider that to be abusive in nature. And like I said, this does include the genitals, and typically, and I think my mouse is probably showing up for you guys, when we're seeing these injuries of the genitals, typically in little boys, and usually as a result of some sort of unrealistic expectation around potty training, not usually from sexual abuse. The E, we went from T in the 10 to E, which is ears. Very unusual to have injuries isolated to the ear. And here you can see some examples where there's just injury to the edge of the ear, usually from someone pinching right along the cartilage. Sometimes we see it on the back of the ear without any kind of injury visible on the anterior surface of the ear. So it's very important when you're working with your medical providers, or those of you who are medical providers on this call, to just quickly pull the ear forward and look behind there, because this little girl, she was slapped across the face, causing injury to the back of her ear when it was crushed against her skull, but she did not have any visible injury on the front of her ear. Here's the N, so neck, injuries to the neck, a very protected area on children and adults, so very unusual to get injuries on the neck from an accidental cause. And here's in that faces part, so the F is for frenulum, and so inside the mouth, in a young, immobile child, it's very unusual to have an injury. They're not up and falling and striking their face. So if we see an injury to the inside of the mouth, causing trauma to the frenulum, which is that small piece of tissue that connects from the inside of your lip to your gums. We typically will see this in an abuse scenario from someone either slapping the child across the face or shoving something into their mouth. We also sometimes will see injuries to the other frenulum. So this one, the frenulum that goes to the lips, we call this the labial frenulum, and underneath the tongue, the lingual frenulum. And these, the frenula do not grow back. So if they're injured and they're torn, that'll persist throughout their lifetime. So we can look and see if there's been prior injury there. A is for the angle of the jaw, and here's two examples of having injuries around the angle of the jaw on these children. And on the fleshy part of the cheek. So this is, classic for not being over a bony prominence. If you think about when children fall, particularly very young children, their weight is disproportionately distributed so that their head is, about 25% of their body weight, as opposed to our heads being 10% of the body weight. So when they fall, typically will lead with their heads, but when they impact into a surface, where you get the injury is from the crush of the tissue between that surface and when it meets resistance, which is where the bones are, which you don't have over the fleshy part of the cheek. Don't have that, it's difficult to get there under your neck, right? That's the protected area. So these are some examples of bruises over the fleshy parts of the cheek, typically from someone grabbing the child across the face. On the eyelid, if you think about, again, striking your head into something, the eyelid is down in this, in your orbit, so it's really protected, and you're going to wind up striking at your brow or on your face, not on the eyelid itself. So typically from a slap or being struck with something that is more flexible and can kind of conform to the face. So again, an unusual location for an accidental injury. And then subconjunctival hemorrhages. We've gained a lot of knowledge about injuries to the eyeballs themselves. So this is what a subconjunctival hemorrhage looks like. It's a collection of blood that you actually see looking at the eye. That's in the sclera. And there's a good study that looked at, almost 34,000 patients. And out of all of those patients, did multiple exams, only 949 of them had subconjunctival hemorrhages, and the vast majority of them were due to what the eye doctors were doing, so either surgery or manipulating the eye. And then when you look at, if you look at the other group, it's all, the vast majority is trauma, with very few being from what we're commonly, is stated in court is that, oh, this is because the patient was coughing or choking. This study nicely illustrates that it's very unlikely to be from that because the prevalence is only 0.5%, and it's primarily due to trauma. Very rare to be a spontaneous occurrence. And so we tend to think in the child abuse world of subconjunctival hemorrhages as a bruise to the eyeball as opposed to some, naturally occurring phenomenon. So that's the faces part of the 10-4 faces, and then the P are your patterned injuries. So anytime you see an injury on a child that has a geometric shape, we would consider that a patterned injury. And you may not know what the pattern is, but that's okay. Just know that if you see something that is not like a globular bruise, that should really raise a red flag, particularly in a child less than 4 years of age, right? This loop mark, classic loop mark, could either be from a belt that's looped over or a cord that's looped over. Really, it doesn't matter which one it is. In either scenario, it's an inflicted injury. Here's two parallel linear marks, one set on the upper thigh and one set on the lower leg. So the linearities of this, them being parallel, that is a pattern. And this could either be from the edges of like a paddle or a ruler, or it could be from a belt if it was struck straight onto the body without being looped over. Couldn't find a good picture of an unlooped belt, but if you strike right on there, you wind up getting injury that outlines the object that strikes the body. This is probably the most distressing photo that we have, but I wanted to put this on here just to kind of demonstrate that you can have patterns within patterns. So here you have the loop mark that we saw before, but then you can also see, because of the uneven surface of the braided rope, that you're getting those undulations as it strikes the body, causing a pattern within the pattern. Sometimes the patterns will overlap. Here you can just, if you step back and look at this, you see that there's lines to this and that they're parallel, but they kind of crisscross. And that's because this child was struck with a belt that had raised edges to it in this orientation and then again in this orientation. So when you have repetitive injuries, it can sometimes be confusing, but if you step back, if you see anything that looks geometric to it, that's a pattern, put those red flags up. This is a pattern injury, which is consistent with a slap mark. On a number of occasions, been asked to evaluate children for this injury. Folks were unsure of what it was, so I want to make sure that you've seen this. What you wind up getting are these, somewhat parallel lines of either petechiae or bruising, and petechiae are those small little broken blood vessels, so you get little red dots. Just bruising around it, but what you're seeing is between the spaces between the fingers, so the intertriginous areas, because it's not a flat surface. When it strikes into the body, you wind up getting injury along the edges of the fingers, and sometimes you can see the fingertips kind of curling over here. If you take a ball of Play-Doh and squeeze it with your hand, you'll kind of see this pattern that emerges. And this is another pattern injury. See how this is very angular. You can see that there's a square here with a protruding rectangle, and this is from the buckle of a belt. You can also see that she also has another one of our 10-4 faces P injuries with this subconjunctival hemorrhage on her eye. This pattern injury is classic for a human bite mark. You're not always going to see it this clearly. If you do see, if you have a case where there's suspected bite mark and there's still some bruising at the center of the bite mark, ask the medical providers to go ahead and collect evidence like they would in a sexual assault case, because we're much better at tying that trace evidence that we collect from saliva using, doing a DNA analysis to the perpetrator as opposed to trying to do some bite mark analysis. This is another pattern, so still in those P's. Know this pattern that's looks like a little smiley face or an arch, like the St. Louis arch. This is classic for a Bic lighter. So if an individual lights this lighter and then holds it for quite some time and then brands it onto the skin, you wind up getting this pattern. This just demonstrates, we put some lipstick on the edge of the lighter here and then did a little lipstick stamp over the injury just to demonstrate that it was the same shape and size as the Bic lighter. And sometimes you'll actually see the striker wheel within the branding mark. So again, even if you're not certain that this is a lighter, knowing that this is a patterned injury is really important. And this is also on the neck, right? So you have two of those 10-4 faces P's. Okay. Switch gears now to abusive head trauma. So abusive head trauma is what we refer to now when we're talking about all types of abuse that involve the head and neck and the central nervous system. This does include shaking, so some folks will still refer to this as shaken baby syndrome, but it is not limited to just shaking. So you can have shaking with or without an impact. We know that you get the same type of forces on the body, onto the head and its contents from abrupt changes in direction such as a shaking or with a sudden halt. So you have that inertial force coming down onto a surface and then suddenly stopping, causes the same type of injury profile to the contents of the head. So you have blunt force trauma is a component of this, and that is from the head rotating within the skull, causing tension on those bridging veins, but then also causing injury to the brain itself. Blunt force meaning that it's not penetrating, so you're not having like a knife or a gunshot wound. And then the other injuries that we see from this are a result of the injury to the brain itself, and that's what we call hypoxic ischemic injury. So hypoxic meaning that you don't have a good amount of oxygen coming to the brain, and that's typically because the breathing muscle, the diaphragm, is impacted as a result of the brain injury, and so you don't have good breathing, and therefore with that dyslabored breathing, you're not oxygenating the blood very well. It's still getting up to the brain, but it's hypoxic. The ischemic part means that there's not good blood flow to that part of the brain. That's typically because the vessels around the injured part of the brain go into what we call vasospasm, and so you don't have good blood supply to that part of the brain, also from edema or swelling of the brain. We can't really always differentiate between the end result of either it being hypoxic or ischemic, so we call it hypoxic ischemic injury. Here's some of the primary injuries that we see to the brain. Now, we don't always see this in abusive head trauma, but if there is impact, you can see a skull fracture. That would be a crack or a break, possibly a depressed fracture of the skull, meaning that when the force was applied to the head, that it was greater than the force of the skull was able to withstand, and therefore it broke. And if it's actually enough to break the skull and then push it in towards the brain, then we call that a depressed skull fracture. Oftentimes we'll see injury that's localized to where that impact was. So if there was an impact, seeing injury to the brain right underneath it, possibly having contusion, so a bruising of the brain itself, or bleeding within the brain, in the parenchyma of the brain. Oftentimes what we'll see is more global bleeding around the brain, which is something we call a subdural hemorrhage, and that's from the brain rotating within the skull and causing the different bridging veins to actually rupture. That typically doesn't cause any consequence to the brain or to the child. It's just a signpost that the brain is actually rotated. What you're seeing outwardly from these injuries are from the injuries to the brain itself. So the localized injuries such as contusions or bleeding within the brain, but more often so from the diffuse axonal injury, which is from the brain moving. And because it's not all the same density, it's almost like if you took a bowl of Jell-O that had fruit in it, and if you moved it very rapidly, where the chunks of fruit are, it's denser, and you have different densities within the brain. And so when it changes direction, you wind up getting tearing around those chunks of fruit in the Jell-O. Same thing happens within the brain. And when it shears those axons, which are the wires of the brain that connect to the body, that's what we call axonal injury. And this will oftentimes cause these infants to become symptomatic within moments. So losing the tone out to their muscles causes them to become limp, and the loss of communication to the diaphragm muscle, causing the breathing to either stop, which is what we call apnea, or it causes them to have disrupted breathing. Oftentimes, caregivers will describe this as grunting or moaning or agonal breathing. So some risk factors for abusive head trauma. Would you like for me to go?
I'll do it. We know there are certain risk factors that put some infants at greater risk for abusive head trauma than others. So babies that are born with multiple health conditions, medically fragile infants. We also see issues and greater risks in multiple births. So twins, triplets, it adds stress on the family, and if they don't have those adequate coping skills, don't have a good support system, then it raises the risk for abusive head trauma. We also know there are some parent and family characteristics that play a role as well. So if this is an unplanned pregnancy, if you have a single parent or a teen or young parent, may not have adequate education around safety and addressing infant crying and the other stressors of parenthood, there may be some improper expectations of what the child can do. You know, we've heard from some of our defect partners that one of the big things that some of the families they work with really struggle with are those improper expectations of the child. So expecting a child to be potty trained or able to be potty trained at 12 months of age. You know, that improper expectation leads to parental frustration, and because they don't have those adequate coping skills, they may get to the point that they violently shake their child. Low income, unemployment, other financial stressors like issues with childcare really play a role in adding stress to that family that then they may need to rely on an unrelated caregiver, and that caregiver then doesn't have adequate coping skills and shakes the child that leads to an abusive head trauma. And then if there's a parental history of other physical abuse, maybe physical abuse of other siblings or other physical abuse of the injured child, we see that that leads to risk factors for future abuse. And we know this happens quite a bit, and I'll let Dr. Messner talk about what we see here at Children's, but we know that there are around 1,300 cases per year in the U.S., and around a fourth of those are fatal. But the actual incidence is unknown because only those that are the most severe and need medical attention actually are brought to the hospital and evaluated for physical abuse. So there are a number of kids who may be experiencing the shaking episodes, may be experiencing physical abuse, but it may not rise to the level of needing medical care. So it's really difficult for us to truly identify how many of these cases truly happen every year in the U.S. We know that other forms of physical abuse are underreported as well. And we know that these cases can also be missed at medical facilities. But we know that abusive head trauma is the leading cause of child abuse deaths in the U.S. And again, it fits into the slide that Dr. Messner showed earlier with fatalities being higher in the under one crowd. And this is why. It's these abusive head trauma cases that are leading to fatalities, because we, again, know that up to a quarter of the cases are fatal every year. So what do we see here at Children's?
It's very similar. We see, a number of cases every year from across the state that get transferred to us to the ICUs because of abusive head trauma. And it's pretty rare that we have a confession, but a couple times a year we'll get a confession, and that's typically a shaking scenario, which does go along with other studies where folks have confessed to injuring a child. That is typically the way that these children are injured. There are other cases that we've seen where children have come in and for another, we found an injury in them, and then we've gone back and looked historically and seen that there's the possibility that they were injured prior to this and presented with a subtle sign. So with typically with vomiting or potentially with a seizure. So those are, some of the other kind of softer signs, like if a child presents to the emergency room and has been vomiting, common things being common, folks aren't going to be, if the child looks well, think that, oh, this is a victim of abusive head trauma, think that this is a viral gastroenteritis, and do that workup. So unless you're actually looking for signs of abusive head trauma by doing imaging of the head, these definitely go missed, except in the cases where it's really, extreme, where they wind up in the ICU, and that's the vast majority of the patients who we see here at the hospital.
All right, so we're going to move into looking at sexual abuse now.
So there are some myths about sexual abuse, that this doesn't occur in normal appearing, well-educated, middle to upper class folks, that, they're somehow immune from being able to molest children. And another myth is that child abusers molest indiscriminately. We know that this isn't true. We know that the vast majority of child abusers who sexually abuse children are known to their victims, and that this is somewhat different than adult sexual abuse, in that in those cases, a large percentage are unknown assailants to the victims. In child sexual abuse, it's typically someone who's either in the household or well known to that child, who is able to groom that child over time. Another myth is that children who are being abused would immediately tell their parents. Again, we know that this is false, that children are often during that grooming process, they're told that this is a secret, or that this is a game, or that if they were to tell, that something bad would happen to them or their family. And so it's often a delayed disclosure. That's the vast majority of the children we see in our clinic here are children who disclose months or even years after the abuse occurred. And the last one is that children who are being sexually abused will show physical evidence of abuse. And that has been disproven. We know the vast majority of children will have normal exams. I'll go into why in this next slide. Why it's normal to be normal. This older paper from Joyce Adams showed that only 14% of cases who were referred for sexual abuse evaluation where the perpetrator was convicted or had a guilty plea or they confessed had abnormal findings. So it's very small amount of them, only 14%, and these are of cases where there was, kind of like the confession literature that we cite in abusive head trauma. This Astrid Hager's study showed it was only, 4% of 2,300 children had abnormal examinations. This older study by De Jong showed that only 7%. So again, very low percentages of kids who had abnormal exams. I think that this paper is a fantastic one where we looked at, in Kellogg's, the second paper here, where they looked at 36 pregnant females. So you can't deny that these children had been sexually assaulted because they were pregnant. And 82% of them had normal examinations. So why are these exams usually normal? It's because of the type of tissue that is present in the genitals and in the anal structures. They're mucous membranes, and they heal rapidly and usually completely. So it's very similar to the inside of your mouth. So if you think about, biting down on your cheek, and I'll often say this if I'm speaking to a jury, that, we've all chomped down on the inside of our cheek to the point where we've tasted blood. Yet if we look inside our mouths, you're not seeing all these scars or seeing all these injuries. So they heal very well. The genital and anal structures are elastic, and so they allow penetration without injury. If there's an allegation of anal penetration or disclosure of that, oftentimes talk about, helping a young child with toileting. And if you look at the size of that bowel movement and they don't have any, there's not like their anus is bleeding or having any kind of trauma from that, you can kind of equate that to what they may have experienced during the assault. And in adolescence, we know that when the hymen is estrogenized, it becomes much more stretchy, more like a hair scrunchie, which allows it to, accommodate penetration and for childbirth. In the younger children, typically, we're knowing that there's other sexual abusive acts that don't involve injury. The pre-pubertal hymen is very sensitive. So, it may be that if the perpetrator is attempting to touch the hymen, that the child withdraws, and so that it's uncomfortable for them. And if they're trying to groom this child, that they actually do not, cause any type of penetration. That's one example about why there might not be an injury there. So if it's a fondling, other sexual abusive acts, such as exposing them to pornography, oral contact, we would not expect that to cause any kind of long-term trauma or acute trauma to the body. There's also this misconception that children actually know, if something's gone inside or outside of their body. It's very challenging for children to know that if something has been placed, whether that be an object, a hand, or a penis between their buttocks or between the labia versus actually going, inserting into the anus or going beyond the hymen into the vagina, it can be really challenging for them to differentiate that. Thankfully, the laws were rewritten that we don't have to actually, show that there was penetration, that there just needs to be contact there, because it's really difficult to ascertain whether or not that actually occurred. Though in some cases, we will have findings that are caused by trauma. So if we do the exam, which is recommended in all children, no matter when they make the disclosure of sexual abuse, they should all be afforded a forensic medical exam to evaluate their genitals for signs of trauma, because not everyone is going to have a normal exam, and we can't make that statement without doing the exam. And a lot of children will have this altered sense of their body image, that they feel that folks can tell just by looking at them that something's happened to them, because there's been this myth perpetuated that you can tell that if someone's had some type of sexual contact, that anybody can tell that happened. So by having them come in and do a medical exam, if they do have a normal exam, then we can reassure them that nobody else would be able to tell this just by looking at their body. And in the cases where there are findings, then we can speak to them and explain the significance of those injuries. So if it's an acute assault, so within 72 to 120 hours or so, we want those children to be seen as soon as possible, so that we can evaluate for any acute, meaning recent, lacerations like a cut or bruising to the structures. And then oftentimes those will heal up completely and without any long-term findings, like I mentioned earlier. But in a minority of cases, we'll see some residual injuries. So we need to be looking for those. Here's some other injuries that we see from trauma to the genital or anal tissue. So if we see bruising or petechiae, abrasions, oftentimes we'll see these on the hymen itself or to the tissues around it. If there's a cut to the hymen, so a laceration, there could be a laceration to the inside of the vagina. If there's a laceration with exposure of the tissues below the dermis, so actually cutting through the mucosal surface, and then we're seeing those deeper injuries. If a child, when we do our exams, we pay particular attention if there's not anything recent or acute, if there's any changes to the hymen from, if we draw a line across the hymen, so from 4 o'clock to 8 o'clock, so that's what we call the posterior rim of the hymen. If we see that there's a defect, so if there's a loss of tissue that goes all the way down to the base of the hymen, that's considered significant because we don't see that as a normal appearance. And if there's actually a loss of tissue that's even wider than just that laceration, we consider that to be significant too. So we need to look for these, and you need to have a trained examiner to go ahead and perform these exams so they can interpret the findings. Then we'll also do testing for sexually transmitted infections. So if there is an infection such as gonorrhea, syphilis, chlamydia, trichomonas, and HIV, if that's outside of the neonatal period, those are significant for being sexually transmitted. So we need to know whether or not this is an adolescent, where it may have been from some, quote unquote, consensual or willing sexual contact, versus in a prepubertal child, we would say that these are diagnostic for sexual contact. Other things that are diagnostic for sexual contact would be pregnancy, and if we identify semen on the sexual assault kit.
So there are some significant risk factors for being a victim of sexual abuse. So are there significant stressors in the family? Are there increased vulnerabilities? So is there, job stress that leads to discord in the family, or they're maybe having to rely again on that unrelated caregiver that increases the vulnerability of that child? Is there an absence of a connection to a safe adult? So do kids have connections outside the primary home? Do they have other people that they can interact with? Are they going to school regularly? Are they connected with, other extracurricular activities where there are other safe adults in their environment? Is there unsupervised or poorly supervised internet use? Perpetrators love to use the internet as grounds to find anybody. They'll start grooming online. And so if kids aren't supervised, or if there's really very minimal supervision, perpetrators know that, and they will capitalize on that. They're looking for those kids who are online at 2 in the morning, because that generally means there's nobody supervising. And that may cross over then into lack of supervision in other areas. Is the child going to be able to sneak out without being noticed? Can they go and meet somebody that they have never met in person, don't really know? Is secrecy permitted or encouraged within the family? We talk a lot when we're doing prevention work with kids about not keeping secrets. And, surprises are great, but we don't keep secrets from one another. And so if you have a family where secrecy is paramount, that's concerning, and it puts that child at risk. Then is there a non-nuclear family structure? So there are step-parents, there are multiple non-relative caregivers in the home. We've seen some increased risk of this during the pandemic, because we've seen lots of families have to rely on other people within the family, other people within their sort of support structure to provide regular ongoing care. You've also had lots of families have to merge, and you've got multiple families or multiple groups of people living in the same household. So what kind of economic stressors are then leading to other risks? Is there violence in the home? Again, this can increase the risk for sexual abuse, just like it can for other forms of abuse. And then if there's previous victimization of the child or of a sibling, we have seen lots of cases where the child has been victimized by more than one adult. And so that previous victimization leads them to be at greater risk for future abuse. So we want to really talk about, okay, so we know what prevention looks like now. What should it look like? And how can changing what prevention looks like in our state better protect our kids? So what we want to do is really move to where the vast majority of our money is focused on that primary prevention, money and time. So it's not just let's throw money at the problem. Let's really look at what evidence-based practices can we put in place that really will make a difference. So things like home visitation. Can we expand home visitation programs? Because they are documented to work. There are multiple studies over multiple years that shows home visitation works to prevent a lot of negative impacts on that child. It can reduce domestic violence exposure in the home, and it can also reduce physical violence and neglect against the child. But generally, home visitation is geared toward high-risk families. So we're missing a lot of people who may not fall into that high-risk category, but could really benefit from the skills and from that connection to somebody who can provide additional education. What kind of parent education can we do in churches, in schools, in other areas where we can really make an impact and help get parents the supports they need to where they're not having to rely on physical discipline. They're not having to, or not feeling overly stressed because they have different skills and they've built those parenting skills. Furthering access to early child care and early childhood education to really, again, boost the supports for the family. They've got adequate and safe daycare for their child, but then also really getting the child in with other adults and getting that child exposure to other safe people within their environment. We do still need to have those secondary prevention tactics. So working with families that we know may be high risk. There might be presence of domestic violence in the home. You may have a substance using caregiver. How can we address those needs so then the parent is better able to support their child? So really meeting families where they are, targeting what those families need as opposed to, the mass universal precautions that we're doing. So sometimes we do need that targeted focus. And then we know we never will get away from needing that tertiary prevention where maltreatment has already occurred. What we want to do is put more of an investment into primary and secondary, so we need less money in the tertiary prevention. I've said for years that I'd love to work myself out of a job. It's not going to happen, but if we can spend more time focusing on our families early, we need less child welfare involvement. We need less foster care. So that tertiary is really focusing on the child and family that has been victimized. And we're wanting to work to try and restore that family. If that can't happen, make sure that that child is placed into a loving, nurturing environment so we can help them heal and hopefully stop additional violence against that child, but really wanting to assist parents in any way we can once that abuse has occurred. There are a lot of different ways that we can do this. The CDC has really identified these methods as great avenues for primary prevention. So strengthening economic support. If we can strengthen our household's financial security, they're not having to rely on unrelated caregivers or people that they barely know to take care of their child so they can work two jobs. We can really focus on job training and education and actually making changes within our employment structure to make sure that our families have financial security. What kind of family-friendly work policies do we have? Is it possible to get to have large employers and small employers change their work policies around paid family leave and making sure that families have that time to bond with their child and they're not having to immediately go back to work right after they bring a newborn home. How can we change our social norms? What kind of public engagement do we do around reducing the use of corporal punishment? Do we bring in legislative approaches to outlaw corporal punishment in schools? What kinds of things can we do that make an impact on abuse and neglect in our kids? Again, that access to quality early childhood care, early education, enhancing parenting skills, expanding that home visitation, and then intervening when there actually has already been harm. So again, looking at those public education campaigns, what kind of social marketing techniques can we look at? You know, so many people are on TikTok and Instagram and Facebook, so how can we use those to change people's views around child abuse and neglect, and particularly around behaviors related to child abuse and neglect? You know, in studies that have been done, when you look at, you know, providing these social media campaigns and social marketing campaigns, they are effective. 44% of parents reported contemplating changing their behavior, and 16% actively tried to stop yelling, swearing, or putting their child down, or fighting or arguing in front of their children. And this is not definitely getting at providing concrete resources to families who need them, but again, it is putting that messaging out there to change the social norms. And then other approaches that have been successful, looking legislatively to reduce corporal punishment use, you know, change the impact. You know, when you reduce the availability of corporal punishment by eliminating it in schools, you're not going to see it, and you're not going to use the severe corporal punishment. There are decreases, and generationally, this has played out with each successive generation. The use and support for corporal punishment has decreased, and so we're continuing to see that play out. And we know that bans are successful in decreasing the use and the societal acceptance of it. So we know that it is possible to make some changes legislatively that then have an impact on whether or not families use corporal punishment in their homes. Some of the other things that we know are successful, you know, providing those parenting skills and really promoting healthy child development by teaching parents what to expect. So providing that support. You know, sometimes it's as simple as just saying, yep, kids can be nuts. And it can be difficult because you're racing to get ready in the morning, and now all of a sudden you don't want to put a coat on. And so you have a meltdown about whether or not you put a coat on or whether or not you put shoes on. That's normal. It's normal to expect that. And give parents skills on how to manage those behaviors. You know, if you expect that you're going to have an argument about a coat, you've decided ahead of time, is this something I really want to fight about? Or do I just say, okay, fine, you can be cold. It's okay. But let parents know that it doesn't mean you're a bad parent when your child argues with you or when you know, are constantly battling over things. It's normal. Teaching those positive parenting skills, alternative discipline techniques, you know, what works for your child that you can use instead of corporal punishment. Some kids respond much better to a reward structure and really praising good behavior instead of identifying bad behavior. So teaching parents how to do that. And then you're really working alongside families to build those strong and safe families. So what are simple ways that if you work with families, you can build those expectations? So then these last couple of slides, because I know we're running short on time, just really give different roles within society. So pretty much everybody who is participating can find themselves on one of these two slides. And so how can we respond throughout society to provide resources and supports for our families to make it easier for our families to feel supported within our communities, and that support then work to reduce child abuse and neglect. So we wanted to end with a funny note. This, the adult in this picture photoshopped his child into really dangerous positions, but no child was harmed in the making of these photos. It's just a little levity, since our other pictures are very disturbing. And here are our emails. If you have questions, want more information, feel free to reach out to us via email. Jennifer, are there any questions from the chat box?
In the chat, it has been busy with just contributions. A lot of appreciation for the pictures that you showed, though they are difficult. Definitely challenging to watch, but we need to hear it, need to know. And then the other is just these calls to action, and how can we build rapport with families to help them be open to these helping behaviors and such. So overall, just lots of great contributions in the chat. No direct questions, just more interaction. So thank you both so much.
Right.
Yes. And
go ahead.
Sorry, the PDF of the slides is available on the conference website.
Yes, if you go down left-hand side materials, you'll see the PDF is there. Also, I've put in the chat the link that we need you to go to fill out the evaluation. You'll need to do that for every workshop that you attend today. Whether you're getting credits or not, we really appreciate the feedback. Dr. Messner, Dr. Boyd, thank you so much for your time preparing and being with us today. Everyone, you've got about 10 minutes before we hop into the next workshop. So thank you so much.
Thank you all.
Thank you.
Enjoy the conference.
Thank you.